first in our series of the Healthcare Coalition Response Series webinars. Today we have a panel discussion on telehealth. We're going to try to discuss not only what we've learned in these last few months, but also start to project forward and thinking about what comes beyond the pandemic. It's on the mind of many patients and many clinicians who are now well-versed in telehealth. So we have a great panel today. I'm going to first ask Dr. Jay Schnitzer, who's on the line, to give us a few words of catch up on how the coalition's doing now that we're at this phase of the pandemic. Jay?
Thanks, FX. Good afternoon, everyone, and welcome. Glad to be here. My colleague, Dr. John Holomka, will not be able to join us, so I'm speaking on behalf of both of us this afternoon, and I just want to welcome everybody. The coalition is still going very, very strong with tremendous interest among the participants, over 1,000 organizations participating. Particularly as we enter the next phase, everybody's trying to figure out how to sustain the energy, sustain the initiative, sustain the work, but also pay attention to everybody's day jobs, and that gets to be an increasing challenge going forward. In that regard, though, the theme that is clearly coming out loudly and clearly across the board is remote for everything. And so as we're seeing, for example, schools, colleges, universities think about returning to the fall semester, more and more are thinking about how do we do it remotely, have been for a time. Some were thinking about a hybrid approach, but if you've been watching the news for the last few days, you realize that many of the colleges and universities that started off with some in-person or some hybrid approach are finding out they have to transition over for a variety of reasons to pure remote or nearly pure remote kind of learning, similar for K through 12. And telehealth is remote healthcare. So and most employers are still keeping many of their employees working at a distance rather than coming into the office on a regular basis. And some, as you know, Google, Facebook, and others have said they're not going to reopen their offices until a year from now, until next summer, and have already made that declaration. So I think the theme is remote, and we need to be thinking about how are these lessons learned that we're all learning from all of these application spaces of remote this and remote that, including telehealth. What lessons learned can be shared among them, because we need to get really good at this going forward as a society. This is going to be with us for a while, and this is clearly one of the approaches that works. So with that, I'm looking forward to this exciting panel to give us some insights, and for that, I turn it back over to you, FX. Thank you.
Thank you, Jay. As the audience knows, we've had about 15 different work groups within the coalition, and one of the most active has been the telehealth work group that's been meeting literally since March and has a number of work streams that are going on. All of the speakers on today's panel have been active in the coalition work group, have participated in presentations earlier, and we asked them to come back to share some of their very compelling stories. So we'll hear first from Jennifer Holloman from Atlantic Health System about their telehealth journey, and then for Alisa Busch and Kara Bachman from McLean Hospital here in Massachusetts, and then to John League, who has kind of an oversight through the advisory board of kind of a national picture related to telehealth. And then we'll turn to the panel discussion, and just before we do that, Helene Sweet and I will present some data that's really hot off the research press in the last 48 hours from our telehealth impact study. I'll talk a little bit more about that at that point. So Jennifer, please take it away.
Great, thank you so much, FX. We're really grateful for the opportunity to present to you all today on some of the lessons learned that we've had at our health system. As you mentioned, my name is Jennifer Holloman. I'm the manager of telehealth services at Atlantic Health System. And given our geographic location, we thought it may be useful to share some of our lessons learned from the COVID response efforts and specifically how we've leveraged telehealth as part of that strategic imperative. A little bit about our health system. We're comprised of 5 hospitals, a rehab institute, and a children's hospital. Our flagship, which is Morristown Medical Center, is located about 45 minutes outside of New York City. And we have a medical group that's comprised of 1,100 physicians across 300 sites that span across northern New Jersey, southern New York, and eastern Pennsylvania. So given that context, we wanted to share some of the data from our primary market, which is the state of New Jersey. I think that all of us as part of this coalition can appreciate the aggressive spread and nature of coronavirus, but it never ceases to amaze me looking at some of the data, just how quickly COVID spread here and the immediacy with which we needed to implement some of our solutions, particularly our telehealth solutions, in an effort to flatten the curve. So you can see at the bottom of our slide here, this is the distribution of COVID cases from March to June, and then some of the timeline specific parameters. So on March 4th, we had our first presumptive case in the state of New Jersey. This is a few days after the first cases in New York. By a week, we had our first cases in Atlantic Health System. Within 3 weeks, we had over 100 at AHS. And then within 5 weeks, we had hit peak with over 840 cases in our hospitals alone, many more in our practices and persons under investigation that were under surveillance. So I think that sometimes it's hard to wrap our minds around the fact that with all the moving pieces that were occurring with the pandemic response and simultaneously trying to stand up telehealth programs and implement technology solutions is something that's been a continual learning process for us. In aggregate, we've had over 187,000 cases as of August 17th and in the state, and we've had over 3,000 here at AHS. So given, again, those timelines and the significant impact that COVID has had on our operations, we really coalesced early on in developing a system-wide strategy and coordinated telehealth response effort focused on 4 key areas. 1, establishing virtual options to triage persons under investigation and align them with appropriate testing. Secondly, how we've leveraged telehealth to manage our inpatient capacity and preserve that where possible. Third, disseminating and deploying video consultations to help flatten the curve. And then finally, disseminating information to scale technology solutions and where necessary pivot based on waiver guidelines. So the first area that we focused on was building virtual options to effectively triage COVID persons under investigation. We started actually with the middle here with an audio-only nurse triage line. This was for a few reasons. First, at the start of COVID response efforts, we did not have a standardized video visit platform or asynchronous capability. So this was something that we could implement with relative ease. And we were able to establish this within 4 days with a few nurses and a few providers. As technology became available, we were able to layer in a self-service symptom checker on our webpage and add bot functionality so that we'd be able to provide automated responses and align patients with resources. Finally, we layered in video visits for patients that required escalation, which provided a higher level of evaluation when providers needed to visually see the patients. All in all, we had over 10,000 calls that were dispositioned through our nurse triage line. At peak, we had over 25 nurses and 5 physicians that were manning this at any given point. So it was one of our lessons learned from COVID response. Secondly, like I mentioned, we were leveraging telehealth technology to help better manage our inpatient capacity. We did this in 2 key areas. We deployed tablets across our hospital facilities and emergency departments. And this was really helpful in 2 ways. One, it provided needed modality within our COVID isolation rooms. So we were able to minimize exposure for our staff and nurses, as well as for family members that were trying to contact their loved ones who were in isolation rooms. Secondly, we were able to leverage these for non-COVID rooms for instances where we had providers who were in self-isolation or quarantine due to potential exposure. So it facilitated remote consultations from hospitalists and other specialists. All in all, we had over 1,200 tablets that were deployed across our hospital locations and emergency departments. The second area that we deployed telehealth in terms of managing inpatient capacity was through a remote patient monitoring program that we developed called Obs at Home. This was really leveraged to help support decanting hospitals that were at capacity. We had an existing RPM capability that we were able to leverage to monitor things like blood oxygen levels, temperature, and symptom monitoring, and combine that with nurse check-ins, which occurred every 2 hours, and a physician video visit. We've focused on both ends of the care continuum, so patients who were presenting to the emergency department who could be, who are otherwise healthy and could be monitored for their symptoms and determine whether they needed escalation. Secondly, we looked at the post-discharge portion of the care continuum to safely discharge patients who were on COVID wards with oxygen for continued monitoring. We had over 400 patients that were monitored through this technology using a combination of home care and care coordination nurses, as well as physicians and specialists, which resulted in 4%, less than 4% readmission rate for that population. And we're still collecting data on that now. The third area that we leveraged telehealth for was disseminating video visits to help flatten the curve. You can see again the distribution of COVID cases over time, and juxtaposed over that is the proportion of in-person and telehealth visits. For some context, most of our practices closed in the late March, early April timeframe, and so this provided a needed modality to safely treat patients in place. You can see that as we approached peak, we successfully transitioned almost 90% of our virtual, all of our visits to virtual modalities, and we've gradually brought back to in-person some of those visits, although I will say that we've maintained a volume of about 1,000 video visits per day. And across our capabilities, we've had over 280,000 audio or video visit encounters across that time frame. Finally, we've found a need to get the word out to quickly scale solutions. Many of our providers had never done telehealth prior to COVID, which meant that we needed to quickly disseminate information and essentially drop ship telehealth information given the dynamic statutory and regulatory environment. Initially, we were sending out blast emails and reporting video trainings, and quickly learned that we needed to have a resource that could be quickly updated given the changes that were occurring at the federal, state, and payer level. So we created a central resource page for our physicians that had FAQs, checklists, and other one-pagers that could be easy reference materials for physicians who may not have done telehealth before. All in all of the regulatory and statutory changes that have been in place have been extremely helpful in standing up our telehealth programs, given these quick timelines, but it has not been without its challenges. So I think that part of the challenge has been just the timelines in terms of some of the changes at the federal level trickling down to state and payer level. And additionally, because we, for example, are in multiple states for our service area, trying to determine which states had passed some of the updates was something that we were continually monitoring and trying to get the word out to our physicians. Additionally, you know, there's still some variation in terms of the payer policies, which is again something that we've continued to monitor as the situation has changed. So again, those are the 4 key areas that we had implemented as part of our telehealth response. We look forward to the questions and Q&A portion.
That's fantastic. Thank you very much, Jennifer. We'll go now to Alisa Busch, who's the Chief Medical Information Officer at McLean Hospital, and her colleague, Kara Bachman, who's the CIO.
Hi, good afternoon. I'm going to just share a screen.
Looks good.
Let's see if I can, yeah, there. Does that make it bigger for everyone?
It's perfect.
That's great. Okay, thank you. Well, thank you. Karen and I are delighted to be here to share our experiences at McLean Hospital standing up telehealth.
Great. So as FX mentioned, I'm Kara Backman. I'm the CIO at McLean. I'm going to just give you a quick overview about McLean, and then we'll jump into some details on what we did in the telehealth space. McLean is a comprehensive psychiatric hospital. Our main campus is located in Belmont, Massachusetts, and we have several satellite locations across Massachusetts and one in Maine. We provide the full continuum of care. We have over 200 inpatient beds, 21 residential and partial hospital programs. We provide outpatient services, and we also have 2 therapeutic schools that support students ages 6 to 22. We have multiple subspecialty clinical programs, and we cover the whole life spectrum of psychiatric care with child and adolescents through geriatric care. We have the largest training or largest, we are the largest psychiatric teaching hospital of Harvard Medical School. We provide on-site training to physicians, nurses, psychologists, and social workers. And we are the largest psychiatric research program of any private psychiatric hospital in the US. And then just to kind of toot our own horn a little bit, for the 18th consecutive year, we are the top ranked freestanding psychiatric hospital.
Go Team McLean. So we also, Karen, I wanted to share with you really at the outset, like what were our telehealth needs for COVID-19, and a lot of it echoes what Jennifer talked about. So I was really delighted to see, Jennifer, you did a much better job in sort of describing the whole background. So thank you, because so much of it applied to us in Massachusetts in general, and certainly, McLean in particular. I would say at McLean, prior to COVID-19, we had done very little telehealth. There was some programs that did some individual and family work with some of their patients using telehealth, but it really was very infrequently used with us. We were hoping to grow it before all of this. We also at McLean, we have a heavy reliance on group therapy at all levels of care. It's a mainstay in so many of our psychiatric treatment programs. Our goals were that we, certainly wanted to move as virtual as we could. So for our outpatient, partial hospital, and school programs, we wanted to go entirely virtual. For the residential programs, that was more challenging. So we had a mixed approach. There were some programs that went entirely virtual pretty quickly, and that, in particular, our child and adolescent residential program. And others made social distancing accommodations, including some group telehealth, in the context of the residential setting. We had, as time went on, some other residential programs went virtual, but not all of them, entirely virtual, I should say, but not all of them. And then on the inpatient unit, we had different goals. We have like 7 or 8 inpatient units actually. So we wanted to enable as much social distancing between staff and patients as was feasible when it's clinically appropriate. We had sometimes patients in isolation due to infection control policies related to COVID-19. We also wanted to preserve the workforce in our clinical teams. Early on in the pandemic, it became very clear to us that we could be facing a critical shortage of providers. Particularly early on, test results would take like 5 days to come back. So if you had a clinician who was having some symptoms, maybe related to COVID-19, maybe not, but then by hospital organizational policy, they could not be on the grounds until their test came back negative, but that could be 5 days. And so we were really worried about our ability to be able to, frankly, staff our inpatient units. And so we wanted to be able to enable clinicians, again, when clinically feasible and appropriate, that some clinicians would be providing telehealth, joining the team who was on site, but they would be joining either from home if they needed to be, or to, again, enable more social distancing on the inpatient units, that perhaps a clinician was in their office and sort of joining into rounds, or to meet with a patient. And so we had all of these goals, and I would say that the most challenging, I think, for us was thinking around the group therapy, because that was a way that we really had to, we couldn't just take the sort of out of the box as our larger organization was standing up telehealth. We had to think very creatively about how to do group telehealth. And also the telehealth platform that we used was Zoom. We have a HIPAA compliant version with a business associates agreement in place. So that's what we used for telehealth. And I'll say that we've spent a lot of time since then doing a lot of monitoring of how things are going, both in terms of, sort of hearing, you know, from providers and leaders in groups, but we've also conducted surveys of providers. How's the experience going? What kinds of difficulties, if any, technical difficulties are you having? And we've also been monitoring our volumes of our visit volumes, both looking at our overall volume and also what proportion are video versus phone. I should say at the outset that once mid-March, our larger organization decided that we should be avoiding, for outpatient care, we should be avoiding in-person visits. We went entirely virtual. Like, I mean, really within a couple of weeks, we were entirely virtual with video, but we stopped seeing patients on our grounds about March 16th, I believe it was. And so now, because we are still entirely virtual in our outpatient setting, we're monitoring how it's going in terms of the overall volume and visits that are using video versus phone. And one thing that we've noticed is that we're certainly able to maintain our volume. Some programs have increased their volume. Some of that's related to, for example, our addiction partial hospital found that it was difficult.
I think we lost Alisa's microphone there. I don't know if Kara, if you want to fill in her line of thinking.
Sure. I think what she was saying with our addiction programs decided that it was difficult to support their standard operations and workflow. So they made some changes where they actually split out some groups as well as did more individualized sessions. So we saw an increase in their visit volume compared to pre-pandemic.
Wow.
And then while we're waiting for Alisa to come back, a couple of other things that I'll just mention, and then certainly we're happy to answer any questions during the Q&A. We did have some, we are part of a larger healthcare system, Mass General Brigham, which was formerly Partners Healthcare. So we were fortunate, like Alisa mentioned, we had very little to none telehealth before the pandemic. There was enterprise tools available to us, so we were able to take advantage of those and utilize those tools. They really were focused on the one-on-one patient provider care. So we spent a lot of time in those first few weeks as we were getting our clinicians up and running on Zoom, really to figure out what was the best workflow to support group therapies. We do a lot of group therapy, and we knew we needed to be able to support that. We spent a lot of time with our Office of General Counsel thinking of things from a legal standpoint, as well as our information security team, to understand what were the best measures that we could put in place in Zoom to really, protect the patients and the providers, and what settings we needed to enable when you're thinking about a group setting compared to one-on-one care.
That's great. Yeah, I think there's going to be some particular interest in learning more about group visits, be they behavioral health or medical. I think there's a lot of opportunity there. That's great. Well, thank you for sharing the story of McLean, and we're definitely going to dig into it a little as we go into the panel discussion. Now we'll
trying to rejoin.
Yeah, she'll get it, I'm sure. We'll ask John League to show his screen and take us through the work he's championing at the advisory board. And John, just remind the audience about the full scope of work that the advisory board's doing.
Sure, glad to do it. Thanks, FX. Hi, John League. I am a senior consultant at the advisory board. We have several thousand member organizations across the United States and globally, providing largely best practice research and assistance to organizations to help think strategically through the issues that they might be facing right now. The big one for my team right now, as we think about telehealth and as we talk to provider organizations, is the question we keep getting is, how many visits should we do virtually? We have ramped up enormously from COVID. We have a lot of interest among patients. For the first time, our clinicians are very engaged in using telehealth. They see the opportunity to solve problems of access, to expand their reach, to be able to connect with patients and fill care gaps, all sorts of applications. And the question that comes from clinicians and from planners and executives is, how many of these visits should we be doing? And I understand how important that can be. Clinicians want to know, how do I structure my day? FX, you and I were talking about this earlier this week. How many of these visits should I do? When should I be doing them? Things like that. Planners and executives need to know, based on how many of these visits we're going to be doing, what does that mean for our programmatic needs? What does that mean for our physical footprint or our staffing requirements? I think all of those things are incredibly important. The challenge is that there's so very little data right now about telehealth. Very easy to overestimate how much telehealth we were actually doing before COVID hit. And so I've seen estimates from individual organizations ranging from 20% of visits going forward all the way up to 60%. Most of those numbers are admittedly made up. I'm sure that organizations are trying to be as conscientious about it as possible, but a lot of those are based on COVID lockdown type surges. Some of them are based on reactions, fear of disruption or other players, and some of them admittedly are very optimistically ambitious. We have done some modeling at advisory board on this, and we do have a number. I'm going to show it to you on the next slide, and then I want you to ignore it, and I'll tell you why. When we think about an overall number for the total number of visits any organization should be doing, one number ignores way too many factors. So the number is here on the left, 26% of outpatient visits that could shift to telehealth. The challenge there is that overlooks all of the individual needs of an organization, its patient population, and its clinicians. We have some of these here on the left. Really a ton of factors that would push that number up and down. The biggest factor, though, is the table here on the right of this slide. If you look at these range of specialties, there's an enormous variation by specialty about what could be done via telehealth. So just to give you some insight into how we came up with these numbers, we didn't just invent them. We have tried to estimate what visits could shift based on clinical ability to perform the visits virtually. So we looked at the CDC's National Ambulatory Medical Care Survey. So this is a survey, this is not based on coding. This is a survey that the CDC has done of what is actually happening in physician practices. What are physicians doing to patients, if you will? And this is all outpatient based. The visits that can be done virtually are those services, procedures, assessments, evaluations that can be performed remotely through secure sharing of information. So this can include anything, any kind of program. It could include things like alcohol abuse screening. It could also include anything that allows for a patient's ability to self-report weight, height, blood pressure, temperature readings, those kinds of things. It is an admittedly blunt instrument to figure this out, but to get an overall sense of a baseline, a starting point, we think it's important to consider these factors. And obviously the range here is enormous, ranging from psychiatry, which is almost every visit, down to ophthalmology and urology, which would be almost no visits via telehealth. Most of the numbers here, as you can see in the big fat part of the screen, ranging from about 20% to 40%. That's a pretty decent number. But again, what I would like for you to do is to forget that I showed you the 26% number at all. Instead, we need to identify what visits could be virtual before we decide how many. And that is a conversation that needs to happen. It is admittedly probably fraught with trial and error, but it is going to have to balance both what patients need and want and what physicians will be able to do. And when I say will be able to do, I don't mean that from a competency perspective. I just mean that from a fluency perspective. Certainly physicians, I think, have risen to the occasion for telehealth, even folks who were not familiar with the modality. If you look at all of the patient experience surveys that have come out, you see that patients are largely very satisfied with the interaction that they have with their clinicians via telehealth. In many cases, rating the interaction as comparable to in-person visit. So I don't think that is the limitation here. But we've covered a lot of issues here that really touch on, you know, every aspect of the patient interaction. And I think all of those things are very important. It's not fair to just weight convenience over utility, or physician fluency over quality of care. I think all of those things are very important and do not lend themselves to a one-size-fits-all sort of answer. No single source of truth. We are developing a tool based on this data that will allow organizations to input data, their own data, and get a range of values from a conservative estimate to a very aggressive estimate, and also looking at incorporating our own consumer survey data and allowing them to adjust those numbers based on the age of their patient population. So that's all I have on that, but glad to answer any questions going forward.
Great, well, that's very helpful. We're going to have plenty of questions, John. I just want to encourage all the attendees and participants to send your questions in via chat, because we're going to have a good conversation in just a few minutes. I'm going to actually show some slides for, telehealth from our telehealth impact study. I'll try to share my own screen here. And remind the group that the coalition has taken up the challenge to try to understand and measure some of the effects and activities in the telehealth space during the pandemic. Our telehealth impact study now includes a number of organizations. The IRB approved protocol was generated through Mayo Clinic, and Dr. Steve Holloman and I are the two principal investigators. The goals of the study really are just to be a descriptive study of the activities of telehealth starting with the beginning of the pandemic. So our data collection includes claims data as well as 2 surveys. This is just, I'm going to only show one slide really from the claims data. We're just at the point where it's ready to start examining. This is a slide of telehealth prevalence during, just actually raw numbers from a large claims clearinghouse called Change Healthcare that has in the data set just over half of all private insurance claims in the country. So it does not include a high number of indemnity Medicare or Medicaid. But we can see patterns here, and we're very anxious to do the full analysis over the next few months as we continue to take data in on a weekly basis. What this slide shows is a heavy uptake and an abrupt uptake of telehealth activity, as we can see starting in February and then really coming on strong in March and April. And in each age group, these are patient age groups, we start to see some decrease in the months thereafter. And the data comes in on a weekly basis, so the August data is only partial at this point. So you see it looks like it drops off, but there's still plenty of activity going on. We also see good uptake in different age groups. Part of the study will be digging into this and then looking at subsets that relate to clinical conditions as well as activity to differentiate different specialists, as well as an interest in understanding, were those clinicians in the same state as the patient, or was the patient receiving care from outside of their own state? And the goal here is to inform regulators in particular about some of those issues that relate to the regulatory environment. The decision dashboard that's sponsored by the coalition continues to grow in sophistication, and just in the last 3 weeks, we've added now some data from the telehealth impact study to look at volume of telehealth activity at a state level. So when you visit the c19hcc.org website, please visit the decision dashboard and be sure to go down and see the telehealth trend data. This is just a picture of what it looks like for in this case, one state, and shows the magnitude of increase compared to the monthly rate of telehealth activity in that state from 2019. And as you can appreciate, it's a big growth number. And what we're seeing is a steady growth or a consistent growth in virtually every state in the nation. The two other parts of our telehealth impact study are a provider survey and a patient survey. We've actually just concluded the provider survey. It ran for about a 4-week period. And just yesterday, I received the first look at some of the data. So I'm going to share 2 slides with you today. This is a question to physicians and other providers who answered the survey about how long they have been using telehealth. In this sample of just over 1,500 providers, we see that the vast majority, almost 80%, have been using it just literally this year. And that really is because of the pandemic. So huge numbers of clinicians, a huge percentage of physicians and providers are having their first telehealth experience along with their patients. And then another interesting question, and the survey has many different questions about aspects of the usability of telehealth and some of the technical aspects. But one question we asked was whether they were using telehealth technology that was already provided through their EHR. And in this survey group, about 40% said yes, and another 60% were using tools and applications outside of their EHR. So much more to go from the survey, and again, encourage you to check out the website for more on the study as it rolls out over this next several months. We'll be distributing the patient survey in the month of September, so be on the lookout for that as well. So I'm going to ask the panelists to turn their cameras on, and I've also invited Helene Sweet, who is a behavioral health specialist and a member of our MITRE team. She's also been very much the point person on our surveys. So Helene, welcome to the team. So we'll start with questions. I think on the minds of many is John had indicated, what's the right balance? I know many hospitals and medical practices are trying to create their templates so they can schedule patients now over the next few months. And we can see a big variation, obviously, by different specialty, and that seems right on the mark. But I thought it would be good to hear from Jennifer, given the breadth of specialties in your organization. What are you doing for the fall? What are your plans as far as that balance of effort and location for your providers and your patients?
Yeah, no, I think that is something that most health systems are kind of, as we've passed the response, we're in rebalancing, trying to standardize workflows. So we are looking at least our data that we've collected so far, where we've had a high volume of video visits, where we've had some challenges. So for example, looking at where there may have been more audio only visits and trying to troubleshoot, has that been a technology issue? Has that been because patients don't have access to a smartphone or tablet? And really doing a deeper dive on those use cases where there's a clinically appropriate or requirement for having a video-based consultation. So right now we're looking at the aggregate data and breaking it down by specialty to determine which ones are, again, we would like to continue doing video versus, audio only. So that's kind of an exercise that we're walking through now, in addition to working on standardizing the workflows in our individual practices.
That's great. Kara and Alisa, do you want to comment about your provider groups and how much leeway do you give them as far as bringing patients back to the office or back to the campus?
Yeah, right now we've made the decision that we are going to keep our outpatient and partial programs virtual through the end of the year, and we'll continue to assess when we bring patients back. Certainly, emergent situations, we would bring patients on site and we would plan for that. The other thing that we're doing, similar to what Jennifer said, and Alisa can certainly provide a lot of details, is we are doing surveys and digging into the data to understand how the different programs are, doing with virtual visits, and specifically around, the different patient populations. And for example, geriatric, we see a higher number of telephone visits than video visits, and we can, dig into that a little bit more. And, certain other groups as well, like psychotic disorders, tend to be more telephone calls than virtual or video visits. But, as we're looking through the data month to month, it kind of seems to change. And good news is there's less telephone visits. I think long-term, the video visits will stay. I don't know that, telephone visits will be supported, post-pandemic.
Thanks, Karen. I would also add, our providers are also telling us, and I think no surprise to people who are experienced with telemedicine, that it's not, even within psychiatry, it's not good for all patients or all scenarios. And so there are, certainly, for example, we're starting to make some plans. Our geriatric psychiatrists are saying, we really want to start seeing some of our patients in the office for some of the visits. We know they're a high-risk group, but there are just some things we can't do as well through video visits. Sometimes trying to see if there's a tremor, for example, or other kinds of physical signs. And certainly it's harder to do vitals. I guess one could do it remotely, but then there has to be someone else, for at least, and often for some of our geriatric patients, to assist them in the telephone visits. So there are some patient populations, particularly vulnerable, where we're finding telemedicine isn't really meeting all of their needs, that we're beginning to explore how can we bring them back safely for some in-person visits. And our ability to continue to do this is going to depend heavily upon how does the landscape change in terms of the regulations and the payment structure for this. I mentioned before the pandemic, we were hoping to go into more telemedicine, but we found it financially not feasible. So if you're discounting the services, it makes it harder for us to do it. In psychiatry in particular, where we know from research that, if you take apples to apples CPT codes, the same widget of service, psychiatry gets paid less for service. So it's particularly challenging then to, say, well, then let's now discount the service even more for whatever reason that we're finding insurance companies, or some insurance companies are saying, well, gosh, you guys are able to do a lot of telemedicine now. So, maybe we should pay, maybe we shouldn't have the parity in the payment that we've had during the pandemic. So certainly the payment is going to be important, and the regulations. Say something about the regulations. Psychiatry is a multidisciplinary field, and the telemedicine rules around particularly out-of-state service are most well defined for physicians, and a little bit better for APRNs, advanced practice nurses, but for psychologists and for social workers, it's a much murkier landscape. And so we've had difficulty, particularly, let's say, our partial hospitals, where it's a team of people taking care of a patient. But we've really struggled. We have referrals who come in from all over New England and the country, and sometimes internationally. But we've really struggled with during this pandemic, how do we serve even our neighbor states? Because the rules for telemedicine, particularly for new patients, for non-physicians or non-APRNs, are really difficult. And so it's been a real limitation for us, even during the pandemic, that because there's so much state-based laws and regulations and licensing rules around telehealth, it can be very difficult to navigate.
That's you touch. I think you both already touched on the point about trying to forecast the regulatory environment. And obviously, one of the things we're trying to do through the coalition is try to bring facts to bear so that we can communicate that. I'm wondering, Helene, if you could talk a little bit about the research that you see developing and how we can make sure that our regulators, our insurance companies, as well as our provider organizations can have the best understanding of what's possible. Hopefully, there's a lot of learning going on, and it's some of them are painful lessons, but hopefully there are a lot of best practices emerging.
Yeah, I think there are, and it's changing every single day, and there's new studies that are being published all the time. So around the parity, I think that's a hot topic, right, Alisa? And there's, it's complicated, especially in behavioral mental health, when you're trying to, service patients that are coming from all over. But I think that's something that, we're starting to see a lot more of recognition of some of those levels of complexity, and ways to try to make it easier for providers to understand and not get caught up in that as they're trying to also deliver care every single day. But I think that's one of the things that we're seeing. I wanted to kind of tie into the survey data, FX, if I could just step back 1 second, and it's very
Sure.
early still, but I wondered if there's any surprises here. So we're starting to look at the data by specialty, and one of the things we asked about is, how strongly do you agree or disagree with the fact that telehealth provides better access to care? And I thought it was pretty interesting because there were 4 specialty areas that really felt very strongly that it was providing better access to care. And those were psychiatry, neurology, gastroenterology, and other non-surgical. And I'm curious if there's any surprises here, around that right now, or any thoughts around that.
Well, at least from my perspective, I happen to be a general internist. Over the years, we do a lot of telephone-based work with our patients, but until COVID, it's been essentially unreimbursed. And so I think there's a real sense of possibility when we understand the needs of, particularly of our elderly population, our chronic disease population, and many times knowing that just a little bit of communication, a reach out, a discussion, an explanation, interpretation of blood glucoses, of weights, of blood pressures, of headache symptoms, GI complaints, we can actually really help a patient substantially with timely communication. And I think the idea that telehealth can be that bridge for us is very, very exciting. So I'm not too surprised by that. It's a little reinforcing to some of the things that I've been seeing myself. John, can you talk a little bit about what you're thinking and what your organization is hearing with regard to the regulatory evolution here? Are you hearing pain points from any, say, of your rural members, or from any particular subgroup?
Well, thanks for giving me such a small question there, Rex. I appreciate that. I'll address that one narrow part of the issue. No, the regulatory environment is something that I want to say is sort of vexing, and is both, there's both an opportunity here to demonstrate the value of telehealth more broadly to payers and regulators, to CMS. At the same time, there are lots of things that we're sort of handcuffed to the political system about. So, for example, if you look at the 2 stimulus bills in Congress, the House bill that was passed earlier this year does have a lot of expansion of telehealth in it. So does the Senate bill. Oh, I'm sorry, the Senate bill has a lot. The House bill does not. There are many other bills in the House that include lots of telehealth expansion. Those are all sort of aggregated in the Senate bill. From a stimulus perspective, everybody seems to want to do this. They seem to want to expand at least the services that are available to be reimbursed, at least from a Medicare perspective, but getting everybody aligned on the legislative calendar is certainly a challenge. You've got a situation where the democratically controlled House has a bunch of bills in the offing that would do all of these things, but it's not in their stimulus bill. The Senate has a stimulus bill that does have a lot of these expansions. When they go to reconcile a stimulus bill, whatever that is in future, maybe telehealth doesn't get addressed in that as a way to go ahead and get a bill passed. So where does that leave us? Well, right now you're seeing action from the states. Lots of states have permanently or have extended their public health emergency regulations through the end of 2021, end of 2020, maybe the end of 2021. New York and New Hampshire both have recently expanded permanently some of their offerings, including audio only for certain sets of their patients. In New York, for example, for their Medicaid and CHIP beneficiaries, largely to get at this element of access, which is certainly one of the biggest challenges to making sure that the folks who could benefit the most from telehealth are able to access it. I would say, though, the access challenges are real. They are significant, especially in rural areas. That said, just because telehealth cannot effectively reach those people now does not mean we should not continue to use it and try it. Far too often I get in these conversations where folks throw out that limitation sort of as a torpedo to the conversation. If it's not going to solve all of these problems, why are we dealing with it? The truth is that there are a lot of opportunities now, a lot of creative ways to use telehealth, a lot of ways that could really streamline practice and make accessing care more convenient to many consumers. We can't lose sight of that just because
set up with InTouch within a couple of days, within a week, the system could not handle the additional, not even the system, the vendor themselves could not handle the increase of the users. So we ended up making it, the Mass General Brigham made the decision that we would move away from InTouch and we would go to Zoom. So we transitioned those 300 plus users very quickly over to Zoom. And then the enterprise team worked to get Zoom integrated into our EHR. So we actually have two versions that we use. We have an Epic integrated version that's really great for one-on-one patient provider care. And then we have Zoom, which can be used as standalone for any patients that do not have, access to our patient gateway or patient portal, and for group therapies.
That's interesting. And I'm sure we're all, we know within the telehealth work group, there are a number of innovative companies that were bringing new solutions to bear. So I think we're really just at the start of this. And as you indicated, John, it's going to be a tremendous area of innovation over the next many years. So it's going to be very exciting. And some of it is going to be dictated by the by payment. But I think our overall hope is that we can figure out what's the best care for patients and try to build a system that meets the needs of the patient specifically, and then is a complement to the clinical practice. But I think we want to keep patients front and center. In that regard, there's a mention in the chat about the American Telemedicine Association that has also been a partner in the coalition, that they have on their website and through their membership organization a lot of information about best practices, including practice guidelines. So that's something that health systems can certainly avail themselves of. One of the topics also mentioned in chat has been near and dear to other researchers I know at MITRE, that relates to broadband access. And that is part of the story that relates to access. I'm just wondering whether at Atlantic Healthcare that became an issue directly with any of your populations within your pretty significant geographic area.
Yeah, especially in the western part of our state, we do have pockets of rural and bandwidth shortages. Many of our patients live in areas where there's spotty cell coverage. I know that as part of our remote patient monitoring program, for example, we've had 4G SIM cards included as part of the package, just to provide that capability where they may not have access to wireless networks. or cell coverage. But that has been something that, again, we've been monitoring in addition to those patient populations that may not have access to the hardware as well. So I think that those are two areas that I know there's been a lot of focus on, even at the federal statutory level, on how we can improve access to broadband coverage and hardware for patients that may not have access to it otherwise.
Yeah, and I'd also like to add, FX, that we've seen that too, even though we don't serve a rural area, that in our larger system, that there's certainly patients more from a health equity and disparity standpoint who struggled to be able to also access care using these technologies. And so there was a real effort made by our organization, to help these individuals, whether it was by going out into those communities to deliver healthcare more broadly, not just behavioral healthcare. Or not essentially behavioral health care, except to help link them into services, but also for the organization to say to providers who were very excited about video visits and our quick ability to stand them up to say, hey, but not all patients can access it, so please don't abandon the phone too, right? Like you have some patients that they're not going to get care at all unless you use the telephone. So, so do what you need to do clinically and don't prioritize video over phone if, certainly video is not possible. We certainly had, unfortunately, populations in our communities who struggled, even though we're not rural.
Yeah, I think that's a great point, Alisa, that has been a proportion of our visits that we've had to maintain just because there hasn't been access. So having the audio only option, especially during the peak when we were seeing so many cases, it was something that was a necessary component of our care continuum.
And I think that's something that we hear increasingly, that we need to rethink or at least incorporate the modality of care delivery into how we think about treating the patients. I've heard some organizations talk about things like titrating in-person visits to the patient. So figuring out for this patient, for their risk levels, for their complexity, what is the right level of in-person, what is the right level of video, what is the right level of secure messaging, what have you, in order to keep this patient on track to maintain their care. I think a lot of the tactical advice that is out there, including advice from my own organization, has been about how do you get somebody in a virtual visit? Like how do you
have had that before now. So thank you all. We're already at the end of our hour. It went by in a flash. So thank you all. Next week, our topic is going to actually focus completely on social and racial disparities that relate to the pandemic and lessons learned. Beginning in September, we're going to be going to a monthly webinar series. And so stay tuned. Thank you all for participating and stay in touch. Stay safe. Thank you.
Thank you.